Good afternoon, ladies and gentlemen. It's my pleasure to give this very brief overview of a poster presentation which will take place over the next couple of days. This relates to a study known as AZURE, which is a trial looking at the role of an agent called zoledronic acid, which you may know is already widely approved for the treatment of bone metastases in cancer. But over recent years, there's been increasing interest in the possibility that this class of agents may affect recurrence of breast cancer, either indirectly through the effects on bone or possibly directly through effects on cancer cells. And in our own group, we've been particularly interested in this and have published a number of preclinical studies, including a recent paper in the Journal of the National Cancer Institute. What this poster is about is a subset of a very large adjuvant trial, which is not ready for presentation, but relates to a subset of 205 patients who received neoadjuvant chemotherapy, either as is standardly given or with the addition of the bisphosphonate zoledronic acid given as an intravenous infusion immediately after each pulse of chemotherapy. These patients then had their surgery, as would be standard practice, and then they went on to ongoing adjuvant therapy with appropriate endocrine treatment or Herceptin, either alone or with zoledronic acid. I'm going to be focusing just on this early part of the study. So because of this possible anti-tumour activity of zoledronic acid, we decided to perform a retrospective exploratory study to evaluate the effect on pathological tumour response of the addition of this agent, zoledronic acid, to neoadjuvant chemotherapy. I must stress this was not a primary endpoint or pre-specified outcome of the study, which is all about the larger effect on disease-free survival. So it is retrospective, it is exploratory. Now, the way that we addressed this was that we hadn't collected the information the correct way to look at neoadjuvant response, so we performed a central blinded review of pathology reports where the primary endpoint was the pathologically assessed residual invasive tumour size. So each pathology report had the size of the tumour measured accurately, and that was reviewed. Secondly, the proportion of patients who achieved what we call a pathological complete response, which means the tumour disappears from the breast and the axillary lymph nodes in response to the preoperative therapy. And we also looked at the number of positive axillary nodes, and not shown on this slide, but also for interest, the proportion of patients who had to have mastectomy because of the residual tumour size. This is a busy slide. The details don't matter, but it's just to show you that the baseline characteristics of these patients were very well balanced. The vast majority of these patients had large, locally advanced carcinomas, T3 and T4 carcinomas. Lymph node involvement was generally not known because surgery hadn't been performed, and about 2/3 were estrogen receptor positive and 20% HER2 positive. So looking at the results, the residual invasive tumour size was 30 millimetres, was a median of 30 millimetres in the chemotherapy alone arm and 20 millimetres in the combined therapy arm. But to look at this in more detail, you have to perform what we call a multivariate analysis to look at all the other parameters that could affect response to chemotherapy, things like hormone sensitivity, HER2 status, etc. When we perform this multivariate analysis, we see that the adjusted mean residual tumour size is 42 millimetres for the chemotherapy alone arm and 28 millimetres for the chemotherapy plus zoledronic acid arm, suggesting that there's a slightly better response in the primary tumour with the addition of this agent. So that difference is highly significant, and you can see the p-value there, 0.002. We also looked at pathological complete response rates. Now, because so many of these patients had locally advanced disease, including inflammatory cancer, not surprisingly, the pathological complete remission rates were low, but these were increased from a little under 6% to just under 11% in the combined arm, and again, performing a multivariate analysis, this is significant with an odds ratio of 3.7, which reaches significance. So what these data suggest is that perhaps zoledronic acid is doing something more than just affecting bone. This is not a practice-changing study. It's a hypothesis-generating study which will lead to the design of specific neoadjuvant trials to look at this in more detail. But it is the first patient-related evidence that this class of drugs may have direct anti-tumour activity. So thanks for your attention.